Welcome back to the deep dive. Today, we are not just exploring a topic, we are simulating a nightmare.
This sounds fun.
Imagine it's 2 a.m., you're the senior resident on call, the emergency room is chaotic, the fluorescent lights are humming, and you are exhausted. You get called to see a patient who looks gray, tachycardic, abdomen distended like a drum, clearly in distress.
And the surgery resident is already shouting about booking the theater immediately.
Exactly, the classic pressure cooker scenario.
Let's make it worse. Imagine standing at the foot of that bed is not just the surgeon, but the external examiner for your MD finals. He's peering over his spectacles, waiting for you to say something brilliant.
Or something incredibly stupid.
Precisely. And that's the real test, isn't it?
It is, and that's the feeling we are tackling today. We're doing a comprehensive audio overview on the anesthetic management of intestinal obstruction and emergency laparotomy. We're specifically targeting this for the MD student, someone preparing for the Gujarat University exams or similar high-stakes boards.
Right.
We've pulled from the heavy hitters. Miller's Anesthesia, Yao and Artuzio, Morgan and Mikhail, and of course, S-DOS for the clinical side, plus some ICU protocols.
The mission then is simple. We need to take this massive topic, which is basically a physiology disaster unfolding in real time, and turn it into a structured, safe, and most importantly, exam-passing oral presentation.
Because in the exam, knowledge isn't enough. You need the right words, the right structure.
You really do. It's about showing you can think safely under pressure.
So let's start where the exam starts. I'm the student. You are the terrifying senior faculty. I'm standing there. My palms are sweating. The examiner asks,
Doctor, what are we dealing with here? I can't just say blocked gut, can I?
You definitely cannot. If you say blocked gut, you've already, lost the gold medal right there.
Okay, so what's the gold medal answer?
You need a crisp academic definition, you say. Sir, intestinal obstruction is defined as a blockage that prevents the normal aboral transit of intestinal contents.
Aboral transit. Okay, fancy words for stuff moving downstream. Precision matters. And immediately, before he even has a chance to ask the next question, you need to show you understand the urgency. You must differentiate between simple obstruction and strangulated obstruction.
Right. Simple means the pipe is blocked, but the blood flow is okay. Strangulated means the blood supply is compromised.
And that is the single most critical distinction for the anesthetist. It dictates your entire approach to urgency.
How big of a difference are we talking about mortality-wise?
It's huge. Simple obstruction has a mortality of less than 5%, according to Yao and Artuzio. But if it's strangulated, that jumps to anywhere between 8 and 25%.
Wow.
It's a massive difference. By saying that up front, you're telling the examiner, I know the difference between a patient who needs fluid and a patient who needs fluid and a knife immediately.
Okay, so why is this such a killer? 15 to 20% of acute abdomens are obstructions. It seems common, but why does it spiral so fast?
It's the cascade. It's a domino effect. Obstruction leads to distension.
The gut swells up.
Right. That distension leads to increased intramural pressure. So, pressure inside the wall of the gut itself. That pressure collapses the tiny blood vessels, the microvasculature. That leads to ischemia,
Lack of oxygen.
which then leads to perforation,
A hole.
and finally sepsis. It's a ticking clock, and every step makes the next one worse.
So when I'm framing this for the exam, I need to emphasize that high perioperative morbidity.
Absolutely. You have to mention the main killers.
Yeah.
Aspiration pneumonia, overwhelming sepsis, and multi-organ failure. If you get a 20-mark question on this, they aren't looking for a simple list of drugs. The question is almost always pathophysiology and anesthetic management.
They want to know if I understand the mechanism of death.
Exactly. They want to know if you understand why the patient is dying so you can stop it from happening.
Okay, let's get into the classification then. Outline Part B says core concepts. If I'm organizing my thoughts for a long answer, how do I classify this without getting bogged down in, too much detail?
Stick to the high-yield classifications. First, you've got mechanical versus functional.
Mechanical is a physical blockage.
A physical barrier, yes. Adhesions are the big one. Yao says they account for 75% of small bowel cases, usually from previous surgeries. Then you have hernias, tumors, volvulus.
And functional is ileus?
Right. Functional obstruction, or paralytic ileus. Yao and Artuzio defines it as diminished or absent motility due to neuromuscular inhibition. Basically, the pipe is open, but the pump is broken.
What breaks the pump?
Oh, lots of things. The common culprits are opiates, sepsis itself, electrolyte imbalances like hypokalemia, and just the stress of recent surgery.
Okay. And distinct from that is the anatomical classification. Small bowel versus large bowel. ESS is the Bible for this clinical stuff. How do I differentiate them at the bedside?
You look at two things.
Ooh.
The vomiting and the distension.
Okay.
In small bowel obstruction, vomiting is early, profuse, and often bilious. The distension is central, right around the umbilicus.
And large bowel.
It's the opposite. Vomiting is very late. Sometimes it's feculent when it finally happens, which is a terrible sign. But the distension is massive and peripheral along the flanks. And obstipation, absolute constipation, no gas, no stool, is a real hallmark of large bowel obstruction.
But for us, as anesthetists, does the location really change our immediate management?
It definitely changes the fluid and electrolyte picture, which we will absolutely get to. But the examiner-oriented classification, the one you need to keep in your head at all times, is much simpler.
Which is?
Simple versus strangulated and high versus low obstruction. That's what drives your anesthetic plan.
Let's dive into the scary part then, the pathophysiology. This is where I feel like I lose marks because I just list things like dehydration without really explaining why.
This is absolutely essential. It's the foundation. If you don't understand the physiology, you will kill the patient during induction. It's that serious. Let's start with fluid sequestration, or third spacing.
In my head, I picture the gut just filling up with fluid, but where's all that fluid coming from?
That is the key question. Normally, the gut is an absorptive organ. Your body secretes liters of saliva, gastric juice, bile, and pancreatic fluid into it every day, and the gut just drinks it all back up.
Right.
When you block it, two disastrous things happen. First, you get stasis, but then you hit what I call the secretory switch.
The secretory switch. I like that.
Yeah. Yow and Artuzio explains that when the pressure inside the lumen gets above about 20 centimeters of water, normal reabsorption just fails. The gut stops shrinking. But it gets worse. It actually starts actively secreting fluid into the lumen.
So it completely reverses its function, from absorptive to secretory.
Precisely. And think about the blood vessels in the gut wall. The veins are thin-walled and low pressure. The arteries are thick and high pressure. As the gut distends, it squashes the veins first.
So blood can get in, but it can't get out.
Exactly. Massive congestion.
Yeah.
This jacks up the hydrostatic pressure in the capillaries, pushing plasma out into the bowel wall, causing edema, and into the lumen is transudate. It's that sponge effect. The bowel wall gets thick and soggy.
And all that fluid is lost from the circulation.
It is functionally lost. It's still inside the patient, but it's not in their blood vessels where it can generate a blood pressure. That is third spacing.
What kind of volumes are we talking about?
In early obstruction, you might lose about 1.5 liters. In established obstruction, maybe 3 liters. In a patient who's already in a shock state, you can have up to 6 liters of fluid sitting in the gut and the peritoneum.
6 liters? That is nearly the entire blood volume of a standard adult.
It is. And that is why they present in profound hypovolemic shock, even if they haven't vomited a single drop. Yao will give us a great rule of thumb here for the exam.
Okay.
If the hematocrit rises to 55%, it suggests a plasma volume loss of about 40%.
That is a massive deficit. So they are profoundly hypovolemic. What about the electrolytes? You mentioned high versus low obstruction matters here.
It matters a great deal. If you have a high obstruction, say pyloric stenosis or something high up in the jejunum, you are vomiting pure stomach contents. What's in the stomach?
Acid. Hydrochloric acid.
Exactly. So you lose hydrogen ions and you lose chloride ions. When you lose acid, you are left with a metabolic alkalosis.
So high obstruction equals alkalosis. Got it.
But a low obstruction is a completely different story. The fluid that's sequestered down in the ileum or colon is rich in sodium, potassium, and bicarbonate. It's from all the biliary and pancreatic secretions.
Ah, so it's alkaline fluid.
Right. So if you lose that, or if it's just trapped and not being reabsorbed, you get a metabolic acidosis. And on top of that, the severe dehydration causes poor tissue perfusion, so you get a lactic acidosis as well.
So most of the really sick emergency laparotomies for obstruction will be acidotic.
Yes. Metabolic acidosis is the hallmark of the late, sick, low obstruction patient. It's a key sign of trouble.
Okay, what about this term bacterial translocation? I hear it thrown around in the ICU all the time, but what's the actual mechanism?
This is the bridge between hypovolemia and sepsis. It's the second big domino. Miller describes it very well. When the patient becomes hypovolemic, the body goes into survival mode. It tries to save the brain and the heart.
It shunts blood away from non-essential organs.
And in a crisis, the gut is considered non-essential, so you get intense splanchnic vasoconstriction.
Right.
Now, the gut is already distended and struggling for blood flow because of the high internal pressure. And now the sympathetic nervous system has clamped down on the arterial inflow. The mucosal barrier, which is just one cell thick, dies. The tight junctions between the cells break apart.
And the bacteria are just sitting there waiting.
Trillions of them, gram-negatives, anaerobes, all sorts. They just walk right across the broken barrier into the portal circulation and the lymphatics. This triggers a massive inflammatory response, a cytokine storm of TNF-alpha and interleukins.
And that causes systemic inflammatory response syndrome, or SIRS.
Yes, profound vasodilation. So now think about this patient. You have a patient who is hypovolemic, so their tank is empty, and now they're septic, so their tank is vasodilated and leaky.
It's that double whammy you mentioned.
The worst combination possible. You can't fill a leaky, oversized tank when you have no fluid to begin with.
That is a terrifying physiological picture. So to summarize for anesthetic relevance, the patient is dehydrated, acidotic, septic, and this is the big one, has a full stomach.
Full stomach is the defining feature. It does not matter if they claim they haven't eaten in 2 days. The gut is full of this septic, toxic, particulate fluid. You must treat them as a full stomach. No exceptions.
Okay, let's move to the bedside. Part 4 of the outline. Clinical features. What am I looking for?
Well, abdominal distension is the obvious one, but look for the subtle signs. Estes talks about the latter pattern of visible peristalsis. You'll only see it in thin patients.
But from our perspective, a tense abdomen is a mechanical problem, isn't it?
It's a huge mechanical problem. It splints the diaphragm.
Pushes it up.
It pushes it up, which crushes the bases of the lungs and dramatically reduces the functional residual capacity, the FRC.
So they have no oxygen reserve.
None. These are the patients who will desaturate incredibly fast the moment you give an induction agent because they have no oxygen store in their lungs. You have seconds, not minutes.
What about the classic dehydration signs?
Tachycardia is the earliest and most reliable sign. Don't be fooled by a normal blood pressure. Estes emphasizes checking the tongue. It'll be dry, coated, sunken eyes. Loss of skin turgor. And Yao notes oliguria, very low urine output with a high specific gravity. The body is desperately trying to hold on to water.
And hypotension.
Hypotension is a late and very ominous sign. If they are hypotensive, it means their compensatory mechanisms, tachycardia and vasoconstriction, have failed.
Oh.
Or they have strangulated bowel, releasing a flood of endotoxins, causing septic shock. Either way, hypotension is a sign of impending collapse.
And the signs of peritonitis.
Guarding, rigidity, rebound tenderness. If you find these, the bowel is likely perforated or already strangulated. This moves the patient from the urgent category to the immediate life or limb category. Surgery cannot wait.
Okay, that brings us to Part C, preoperative assessment and resuscitation. I need to assess this patient and get them ready. What are the high-yield assessment points I need to nail for the exam?
Hemodynamic status first. The pulse rate is your index of severity. Then a volume depletion assessment, look at the hematocrit, look at the urea and creatinine.
Okay, now here is a classic Viva trap. I see a high urea and a high creatinine. My first instinct is to say acute renal failure.
And that is the trap. If you say renal failure in the Viva, you might fail that station. It is almost always pre-renal azotemia.
Meaning the kidneys are fine, they're just dry.
Exactly. The kidneys are working perfectly. They just have no fluid to work with. The proof is that the urea is often disproportionately high compared to the creatinine.
Why is that?
Yao points out that digested blood from ischemic gut or swallowed blood increases the body's urea load. So a high urea with very concentrated urine equals severe dehydration, not intrinsic renal failure. The treatment is fluid, not fluid restriction.
Got it. What about electrolytes, specifically potassium?
Miller emphasizes checking potassium. It's critical. Hypokalemia is very common because of vomiting and losses into the gut. And this is important. Hypokalemia itself makes the ileus worse. The gut muscle needs potassium to contract.
But there's a flip side, isn't there?
There is. Hyperkalemia is the real danger you're looking for. If they have dead bowel, extensive tissue necrosis, or severe acidosis, cells lyse and release massive amounts of potassium, you absolutely must know the potassium level before you choose your muscle relaxant.
We will definitely get to succinylcholine in a minute. Acid-base status.
Get an arterial blood gas. Don't rely on a venous one. You are looking for a metabolic acidosis. And specifically, you're looking at the lactate.
What's the critical number?
A lactate level greater than 2 millimoles per liter. In the context of intestinal obstruction, a high lactate is a massive red flag for bowel ischemia or strangulation.
Okay, resuscitation. This is outline part 6. The surgeon is screaming, "We need to cut now." The anesthetist is saying, "Wait, the patient's not stable." Who wins that argument?
The patient wins if you negotiate correctly. The principle from both Yao and Miller is crystal clear. restoration of intravascular volume before induction of anesthesia.
So fluids first.
Always. You cannot safely induce a profoundly hypovolemic patient. The induction agents will cause vasodilation, and you will have a catastrophic drop in blood pressure, potentially a cardiac arrest.
So how do I phrase this to the examiner to sound safe but not obstructive?
You say, "So my primary goal is to optimize the patient's hemodynamic status, but I will not unduly delay life-saving surgery. I will initiate aggressive, large-bore IV access and begin rapid fluid resuscitation immediately."
What fluid do I choose?
A balanced salt solution.
Uh-huh.
Ringer's lactate or Plasmolite are the top choices.
Why not normal saline? That's what's always lying around.
Because if you give large volumes of normal saline, the high chloride content will cause a hyperchloremic metabolic acidosis. The patient is already acidotic. You don't want to make the picture more confusing.
And why not a glucose solution like dextrose?
Never glucose for resuscitation. It causes an osmotic diuresis. It makes them pee out more water, worsening dehydration. And if there's any ischemic injury to the brain or gut, hyperglycemia makes the neurological and tissue outcome significantly worse.
Nasogastric tube. Essential.
Mandatory. Both Morgan and Yao are clear on this. You must decompress the stomach. It reduces the risk of aspiration, and it dramatically improves ventilation by allowing the diaphragm to move down.
But does it actually empty the stomach?
No, and that is a huge Viva trap. The NG tube sucks out fluid and gas. It does not suck out the solid food from 2 days ago. The particulate matter stays behind. The patient is, and always will be, a full stomach risk.
Okay. Last thing before the OR antibiotics.
Broad spectrum, and give them early. You need to cover gram-negative aerobes and anaerobes, something like a cephalosporin plus metronidazole, or a single agent like piperacillin tazobactam. ICU protocols are clear. Give it before the incision. Sepsis mortality increases by about 8% for every hour you delay antibiotics.
Okay, the patient is as resuscitated as they're going to get. Let's move to the operating theater. Part D, anesthetic management. The exam asks me for the main anesthetic challenges. How do I list them?
List them on your fingers. 1, full stomach, meaning a massive aspiration risk. 2, hypovolemia, meaning a risk of hemodynamic collapse on induction. 3, sepsis, meaning vasodilation and myocardial depression. 4, severe electrolyte disturbances. And 5, respiratory compromise due to the distension.
That's a lot of challenges. Let's tackle the biggest one first. Airway management. Part 8. This is where we earn our money. Rush.
This is it. The single most dangerous moment. The indication for rapid sequence induction, or RSI, is absolute. Morgan and Miller state this is mandatory. There's no debate, no LMA, no mass ventilation. It's RSI.
And before RSI, pre-oxygenation.
It is vital. 3 to 5 minutes of tight-fitting mask with 100% oxygen. Or, if you're really short on time, 4 vital capacity breaths. Remember, their FRC is crushed by that distended abdomen. They have no reserve. They will desaturate in seconds if you don't do this properly.
Okay, let's talk about cricoid pressure. There's so much controversy about it in the journals these days. What do I say in the Gujarat University exam?
In the exam, you are a believer. You stick to the standard of care. You say you will perform Selleck's maneuver. Apply 10 newtons of pressure while the patient is awake, and increase it to 30 newtons once consciousness is lost.
Even though Miller points out that MRI studies show the esophagus is often lateral to the ring.
You can mention that to show you've read Miller and you're up to date.
You
can say something like, "Sir, while I am aware that recent literature, including Miller, notes variable anatomy, the established safety protocol for an emergency full stomach induction remains the application of cricoid pressure to prevent passive regurgitation."
That sounds like a safe answer.
It is. It shows you know the standard, but are also critically aware of the literature. Always have a backup airway plan, too.
Of course. The can't intubate, can't ventilate drill.
Have a bougie ready. Have a video laryngoscope available if possible. And if you anticipate a difficult airway from the start, say a morbidly obese patient with a huge abdomen and a short neck, Morgan suggests you should strongly consider a weak fiber optic intubation. Don't burn your bridges with muscle relaxants if you aren't 100% sure you can tube them.
Right. Let's move to part 9, induction. The patient is on the table. Their BP is 90/60, heart rate is 120. What induction agent do I pick?
This is a critical decision. ICU protocols in Miller are very clear. You should avoid propofol and thiopentone in hemodynamically unstable patients. They are profound vasodilators and myocardial depressants. They will cause a crash.
So what do I use instead?
Your 2 main choices are ketamine or etomidate.
Let's talk about ketamine first. Why is it a good choice?
Ketamine, at a dose of 1.5 to 2 milligrams per kilogram, is a sympathomimetic. It stimulates the release of the body's own catecholamines, which helps to keep the heart rate and blood pressure up. In a shocked patient, it actively supports the circulation.
But doesn't it cause hallucinations and bad dreams?
In an emergency laparotomy for a dying patient, we care about survival, not about bad dreams. You can always give a small dose of a benzodiazepine later to mitigate that. Survival first.
And the other option? Etomidate.
Etomidate at 0.2 to 0.3 milligrams per kilogram is famously the most cardiostable induction agent we have. It has minimal effect on blood pressure.
So why not just use it every time?
The big concern is adrenal suppression. It can inhibit cortisol production, which isn't ideal in a septic patient who needs a robust stress response. However, for a single induction dose, most examiners will accept it as a very safe cardiac choice.
And the dosing strategy for either drug.
The principle from trauma anesthesia applies here. Start low, go slow. But more accurately, you need to reduce your dose. In a shocked patient, the circulation time is prolonged. You inject the drug, and it might take 60 or even 90 seconds to reach the brain. If you get impatient and inject more, you will cause a massive overdose when it all arrives at once.
Right. Muscle relaxants, the big debate. Succinylcholine versus rocuronium.
Morgan will tell you that succinylcholine at 1.5 milligrams per kilogram is still the gold standard for RSI. Its main benefit is its incredibly fast onset, around 45 seconds, and its short duration of 5 to 10 minutes.
But the contraindication is a huge deal here.
It is hyperkalemia. If the patient has extensive bowel necrosis, crush injury, or renal failure, giving succinylcholine can cause a massive fatal release of potassium, leading to immediate cardiac arrest.
So if the K plus is high, or if it's unknown and a very sick patient,
You absolutely cannot use it. You must use rocuronium. This is often called a modified RSI. The dose is higher than usual, 0.9 to 1.2 milligrams per kilogram, to get a fast onset.
But that lasts for 60 minutes or more.
Yes, so you better be damn sure you can secure that airway. When you give high-dose rocuronium, you are committing to a long block. There's no going back.
Okay, we're intubated. Maintenance.
Balanced anesthesia. Oxygen, air, and a volatile agent like isoflurane or sevoflurane.
What about nitrous oxide?
Absolutely forbidden. This is a very high yield point for any exam. You must know this.
Explain the physics. Why is it so bad?
It's all about Boyle's law and blood gas solubility. Nitrous oxide is 34 times more soluble in blood than nitrogen is. The trapped gas in the obstructed bowel is mostly nitrogen from swallowed air.
Okay.
When you give nitrous oxide, it rushes from the blood into that gas-filled bowel loop much, much faster than the nitrogen can get out.
So the pocket expands.
It expands rapidly. The pharmacology textbooks say the volume can increase 2 to 3 times over. You will turn a distended gut into a ruptured gut on the operating table. And even if it doesn't rupture, it makes it impossible for the surgeon to close the abdomen.
Right. Part 10, intraoperative management. We are in. The surgeon takes the knife to the peritoneum.
Prepare for the crash.
The so-called declamping phenomenon. Tell me about this because it happens so fast.
Think of the tense, distended abdomen as a pressurized compartment. That high pressure is actually compressing the inferior vena cava and the aorta, artificially keeping the blood pressure up.
It's like an abdominal tourniquet.
Exactly. The surgeon cuts the peritoneum, whoosh, all that pressure is released. The IVC suddenly opens up, which sounds good for preload, but simultaneously the compression on the huge mesenteric vascular bed is released. Blood pools rapidly into the gut.
Creating a state of relative hypovolemia.
A profound one. And it gets worse. That sudden reperfusion washes out all the toxic metabolites, lactate, adenosine, potassium, inflammatory mediators that were trapped in the ischemic gut. They hit the heart all at once.
So you get myocardial depression on top of vasodilation.
And the BP drops like a stone. You must anticipate this. Have your fluids running wide open before the incision. Have your vasopressor like phenylephrine or noradrenaline already drawn up, connected to the line, with your finger on the plunger.
Speaking of vasopressors, the ICU books suggest noradrenaline is best for septic shock.
It is, especially for the vasodilation of sepsis. But the rule is always, fill the tank first. Squeezing an empty heart with pressors is useless and dangerous. Volume first, then pressors if needed.
Temperature control, how important is this?
It's part of the lethal triad of trauma and critical illness. Hypothermia, acidosis, and coagulopathy. They all feed each other. A cold patient bleeds. A cold patient's clotting factors don't work. A cold patient's heart is irritable. You must use warm fluids, and you must use a forced air warmer like a bear hugger. Do not let them get cold.
Okay, let's talk about when things go wrong. Intraoperative complications. Part E. We mentioned aspiration. What do you do if it happens?
If you see gastric contents come up, it's Mendelson syndrome, a chemical pneumonitis. You immediately tilt the table head down, suction the oropharynx thoroughly, and then intubate and suction down the endotracheal tube.
And then
Deepen the anesthesia to prevent coughing and bronchospasm, and apply PEEP to keep the alveoli open. Morgan says specifically, do not give prophylactic steroids.
Right.
They don't help, and they increase the risk of secondary bacterial infection.
What about arrhythmias?
If you see arrhythmias, your first thought should be electrolytes. Is the potassium or magnesium low? Second, is the patient too light? Handling the mesentery causes huge autonomic reflexes. Or third, are they becoming profoundly acidotic or hypoxic?
Postoperative management. Part 12. The surgery is done, the bowel is resected. Now comes the big decision. Do we extubate this patient on the table?
This is the judgment call that often fails students in exams. The safe answer, and usually the correct answer, is no. Do not extubate a cold, acidotic septic patient who has had massive fluid shifts and now has a tense, freshly closed abdomen.
Why not specifically?
For three main reasons. One, acidosis. They need to hyperventilate to blow off CO2 to compensate. They might be too weak from surgery and sepsis to sustain that work of breathing. Two, abdominal hypertension. The abdomen is sewn up tight. It's still pushing the diaphragm up, reducing their tidal volume. And three, hypothermia. If they're cold, they will start shivering violently on emergence. Shivering increases oxygen consumption by up to 400%. Their compromised heart can't handle that demand.
So the plan is transfer to the ICU, ventilated.
Yes. Keep them sedated and ventilated overnight. Correct the acidosis. Warm them up fully. Let the fluid shifts settle. Then, you can plan for a safe, controlled extubation the next morning when they are stable.
Let's talk about that fluid balance post-op. Yao mentions this phenomenon of autoinfusion.
This is a critical concept for day 2 and 3. All that fluid that you poured in, which then sequestered into the third space, the gut wall, the peritoneum, starts moving back into the blood vessel.
The sponge gets squeezed out.
Right. And if you are still pumping in IV fluids at the same high rate on day 3, you will easily throw them into massive fluid overload and pulmonary edema. You have to recognize this mobilization phase and start restricting fluids.
Pain control. This is tricky. We know opioids cause ALES.
They do. But uncontrolled pain causes a huge sympathetic stress response, which also slows the gut. You need a balance. The modern approach, as Miller suggests, is multimodal analgesia, using non-opioid drugs like acetaminophen and potentially IV lidocaine infusions, which can actually help gut motility. Epidurals are the gold standard. They provide amazing pain relief and actually improve gut motility by blocking the sympathetic outflow.
But there's a catch.
Of course, you can't safely place an epidural catheter in a septic, potentially coagulopathic patient. The risk of an epidural hematoma is too high. So in the true emergency setting, you often rely on things like rectus sheath blocks or transversus abdominis plane blocks instead.
Special scenarios. Part 13. Let's talk about the sickest of the sick. Obstruction with established sepsis and perforation. The patient is dying on the table.
This is where you need to know the concept of damage control surgery. If the patient has developed that lethal triad acidosis with a pH less than 7.2, hypothermia below 35 degrees, and a clinical coagulopathy, you stop.
You stop the surgery, mid-operation.
You stop the complex definitive reconstruction. The surgeon's job is just to control the source of contamination staple off the bowel ends, wash out the abdomen, and that's it. You leave the abdomen open, cover it with a sterile dressing, and get the patient to the ICU immediately.
And then what?
You spend the next 24 to 48 hours in the ICU doing damage control resuscitation, warming them, correcting the acidosis and coagulopathy, supporting their organs. Then, once they are more stable, you go back to the operating room for a planned second look and definitive repair. If you try to sew bowel together in a dying patient, the anastomosis will leak and they will die.
What about the elderly patient, part 14?
Everything is harder. They've reduced physiological reserve, their hearts are stiffer, their vessels are stiffer, they are very sensitive to fluid overload, but they also tolerate hypovolemia extremely poorly. There's no margin for error.
So what's the key phrase for the exam?
Start low, go slow. That applies to all your drugs. A standard induction dose of Propofol that would be fine for a 40-year-old can be lethal in a 90-year-old with obstruction and sepsis. You must titrate everything very, very carefully.
Okay, let's bring this all home. Part G, exam integration. Examiners love comparison tables.
They do, so you should have a few ready in your mind. Table 1, elective laparotomy versus emergency laparotomy.
Okay.
Elective, NPO, fasted, emergency, full stomach, elective, hemodynamically stable, emergency, hypovolemic and septic, elective. Standard induction, emergency, mandatory RSI.
And Table 2, obstruction versus perforation.
Good one. Obstruction. Usually colicky pain initially has increased bowel sounds, what we call borborygmy, and no gas under the diaphragm on the x-ray, at least initially.
Whereas perforation?
Perforation is a constant severe pain. The abdomen is classically silent because of the chemical peritonitis, and you see pneumoperitoneum-free air under the diaphragm on the chest x-ray.
Viva traps. Part 16. Let's list the common ways students fail this station.
Number 1, inadequate resuscitation. Going to sleep before you fill the tank. Number 2, skipping RSI. Trying to use an LMA or mask ventilating a patient with an obstruction is an immediate catastrophic fail.
What else?
Number 3, poor postoperative planning, especially extubating an unsafe patient on the table. And number 4, that renal failure mistake we talked about, and withholding fluids from a dry patient.
And what are the examiner-approved safe answers?
Always come back to safety. I would optimize the patient, but not unduly delay life-saving surgery. I will assume a full stomach in all cases of intestinal obstruction. And if you're ever truly stuck, at this point I would call for senior help. That's a sign of maturity, not weakness.
Let's talk about structuring that 20-mark written answer. The outline mentions using diagrams.
If it's a written paper, absolutely draw. It breaks up the text and shows you can organize your thoughts visually. Draw a simple pathophysiology flowchart. Obstruction leads to distension, which leads to secretion, which leads to dehydration and ischemia. Draw the simple 5 steps of the RSI algorithm. It saves time and gets you marks.
And for the long case presentation, how should I start?
Start with a crisp summary. I have examined Mr. X, a 55-year-old male presenting with acute abdominal pain and distension. My provisional diagnosis is acute intestinal obstruction, likely affecting the small bowel, complicated by severe dehydration and sepsis. He is an ASA classification 3E or possibly 4E.
The E for emergency is crucial.
It is. Then immediately state your anesthetic goals. My goals for management will be 1. Aggressive preoperative resuscitation. 2. Securing the airway safely via RSI. 3. Maintaining hemodynamic stability intraoperatively. And 4. Planning for postoperative ICU care.
What if they press me on the fluid deficit? How do you calculate it, Doctor?
Be careful with quoting exact formulas unless you're very sure. But you can use general rules to show you understand the scale of the problem. You can say, based on clinical signs, you estimate a severe deficit, which is about 10% of body weight. For a 70-kilogram man, that's a 7-liter deficit.
Just saying that shows you grasp the severity.
Exactly. It impresses examiners.
Okay, let's wrap this entire deep dive up with a final summary. Give me the bullet points I need to be reciting in my head on the way to the exam center.
Right. Here we go.
Fluid sequestration is massive due to third spacing. This is the primary problem.
Dehydration is often masked by a normal BP initially look at the heart rate and urine output.
Resuscitate with balanced salt solutions before you induce.
RSI is mandatory. No shortcuts.
No nitrous oxide. Ever.
Anticipate profound hypotension on opening the abdomen, the declamping effect.
Do not extubate if the patient is cold, acidotic, or has a tense abdomen.
Sepsis needs source control. That's the surgery plus early broad-spectrum antibiotics.
And finally, a model conclusion paragraph for a long answer.
In conclusion, the anesthetic management of a patient with intestinal obstruction is a significant challenge that hinges on a thorough understanding of the underlying pathophysiology of profound fluid shifts and septic shock. Success depends on a systematic approach. Aggressive preoperative resuscitation, meticulous securing of the airway via RSI to prevent aspiration, proactive management of hemodynamic instability, particularly during abdominal decompression, and vigilant postoperative critical care to navigate the recovery phase.
Doctor, that was a marathon, but an incredibly useful one.
It's a huge topic.
Yes.
But if you stick to the principles of physiology and safety, you'll be fine. You'll pass.
To our listener getting ready for that exam, you have the knowledge now. You know the traps. Go in there, be safe, be structured, be confident.
You got this, and good luck.
Thanks for listening to The Deep Dive.
We'll see you on the other side.